The winning innovation, I think, is going to be whatever works for that patient. Because I do think that different patients have different needs, and it's no different from what Chris and Gaurav and Jason and all those have shown, is that there are many tools because you need that many tools. And not all of them work for every patient. And I think it's going to require the active toolbox where a physician can choose what they need to do for that patient. Because we all know TAVR is not mitral. That's been beaten to death. But the mitral has so many different segments that have to be addressed, and they're all different from patient to patient.
Do you think the transapical approach is going to be a, sort of an obstacle, and instead of the sort of venous approach to the?
I've always felt that the sooner we can get away from the transapical, the better, because I do think the feasibility of transseptal has already been demonstrated, and I just think it's a matter of time before technologies get there.
Yeah, and I think the imaging component is really going to be important, because we can build anything. You know, you can, I mean, surgeons are already doing everything. We can make a catheter, but the problem with catheters, we can't see what it is we're doing in the heart while it's beating. And if you think about our imaging, I mean, we really just still have TE. You know, the fusion imaging is interesting. I think it's not really prime time technology myself. I think it's pretty to look at. I haven't found it to be consistently helpful in talking to other people, but I think intracardiac imaging with true 3D, 4D imaging, being able to see everything with an ICE catheter, I think that's really going to be a huge leap forward.
I have a question for you, Maurice. So we have so few expert mitral surgeons. I mean, Gaurav showed his volumes. There's so few people who do that, and my feeling is because it's technically quite challenging. How do you see these devices meeting those unmet needs? Will it make it to where I can do things like Gaurav and David Adams and such, or will it?
I think it will be complementary, but you see, not being an interventional guy, when I'm with a patient, my first thinking is the risk that they're going to be taking. So the main thing is there is the durability, but there is the risk that we're going to take tomorrow. And it's troubling when you look at the STS registry, where you had, 8.5%, 9% of 30-day mortality. And you say, okay, it's supposed to be safe, but it's high. When I'm thinking about the moderate MR, that maybe we want to begin to treat by percutaneous method, are we going to be offering a 0.2% procedural risk? And that's where the safety of the device that we're going to do, of the procedure, in my point of view of consumer of interventional services, is going to be critical in developing and resolving that issue of safe but still high risk in practice. So I don't know what the others are thinking about that.
Paul, I just wanted to add, I do think that even transcatheter technologies, there's a huge learning curve. You've shown data in the TVT registry. Experienced centers with MitraClip have better outcomes. We've seen new centers in our surrounding region that are starting MitraClip have poor outcomes. And so I don't think it's isolated to just the select surgeons that do a lot. I think this is true with the mitral valve in general. Like you said, it's not the aortic valve. It's a lot more complex. We're limited by a number of things, imaging being one, as well as the complexity and variation. And I think that's one thing that makes it challenging is the variability from patient to patient. And we see that in the OR. I mean, there are many patients that have a P2 prolapse or flail, but they're all different. Some are tall, some have short P1, some are very wide. And that plays into why we might choose one technique versus the other. And you now take that a step further away where you're maybe not seeing that quite as clearly. You're using echo, and you can see how that variability plays into variation in outcomes as well with catheter-based approaches.
But I do think that the transcatheter option offers the opportunity to level it so that variability is reduced. So because you are offering something that can be looked at, and the efficacy, the effectiveness can be looked at in real time without the heart under cardioplegia, and you can determine right then whether or not certain tools need to be done or things can be done differently. And there are many more mitral clip operators than there are mitral surgeons, and I think it's because it has reduced that variability in the skill that's been required for the techniques.
I agree with what Jason said. I think the more robust our imaging, the better our time zero result is going to be. And what you get in the lab, it has such an impact on not only long-term durability, but some of these intermediate severity mortalities you're talking about can be linked or traced back to the time zero result. So I think the more robust our imaging becomes, the better we understand imaging, the better the intermediate and long-term results are going to be. And I think that's common sense.
Yeah, no, it is absolutely true. I think that what we're missing is a sort of common set of measures. We don't measure the
Right.
annular size.
Right.
We don't have a 3D measurement. We
Right.
don't have an idea about how much tissue do you have, how much redundancy, is there annular disjunction, what part is the most involved. All of that, we're doing treatment of mitral valve disease, and we have zero measurement at baseline to say, okay, the clip failed because the annulus was so much, because the valve tissue was so much. And we don't have any idea because we don't do a measurement. We see an image and we say, okay, let's treat that, but we don't have the measurement. So
Let me ask Andrew, so from an imaging standpoint, I mean, is it because, why has an innovation, is it because the financial, pictures, and it's a non-disposable, you have like a probe, you don't make money every time you do a case, you sell one probe. Is the financial reward for innovators to do imaging, is it somehow less, you think? Is that why we lag in imaging?
We don't have the automated measurement. I'm sorry, I interrupted you. You see, one of the things is when we look at 3D, we have hundreds of cases. How many did we do 3D complete measurement? 60 cases, because it takes hours of a fellow tracing and measuring, and we need the industry to give us automated measurements that are reliable. So you do the TE, you have your set of measurement of annular size and everything that comes out, and the surgeon knows, oh, it's going to be a lot of tissue. I think I'm going to do a resection on this case. Oh, here there is positive tissue. I'm going to do something different. I'm going to support the valve instead of resecting. So that if we had those measurements at the time of diagnosis by doing a simple TE and automatic measurement, we can't have 3 hours of measurement by patient.
I was just going to answer that specifically. I think that what we have today is what we had before we were doing these interventions. Right. And so we're making use of what existed. We need things now that are tailored for this therapy, and it just takes time. It is happening, and there is a tremendous incentive for the imaging companies to be actually looking at this.
But there isn't tremendous incentive for hospitals and teams, structural teams, to devote the dedicated personnel. It makes no financial sense at all. And so we're having to go outside the system, the hospital systems and the teams, to get expert imaging, because it doesn't make financial sense to have people doing full-time imaging. It does not.
Yeah, there's actually an overlooked paper from an ACC working group. It was published in American Heart Journal 2016. It's a task force that queried valve centers of excellence. They looked at 106 centers and they asked them, how many of you are confident in your echo? 19% of these centers said no. And that's among the valve centers of excellence. So just imagine what that would be like in the community. It's a real problem. Yeah, it's a real problem. All right, should we conclude? All right, well, thank you very much, everyone. Thank you.